Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Welcome, everyone, to the Functional Medicine Discussion Group meeting tonight on an integrative approach to diabetes care. And we're very happy to be joined by Dr. Mona Morstein. I'm Dr. Ben Weitz, and I'd like to make some introductory remarks before making some remarks about our sponsor, and then I'll introduce our speaker and we'll get started. So I encourage each of you to participate and ask questions by typing in your questions in the chat box. And then I'll either call on you or simply ask Dr. Morstein your question when it's appropriate. So I hope that you'll consider attending some of our events in the future. April 28th, we have Dr. Paul Anderson speaking on an integrative approach to cancer. And May 26th, Dr. Sarah Thompson will be speaking about a functional approach to maternity. And then the next meeting after that will be June 23rd, and that's yet to be determined. So if you are not aware, we have a closed Facebook page, the Functional Medicine Discussion Group of Santa Monica, that you should join so we can continue the conversation when this evening is over. I'm recording this event, and I will include it in my weekly Rational Wellness Podcast, which you can subscribe to on Apple Podcasts, Spotify, or YouTube. And if you do already listen to the Rational Wellness Podcast, I'd very much appreciate it if you could go to Apple Podcasts and give me a positive ratings and review. So now I'm very happy to tell you about this evening's sponsor, which is Integrative Therapeutics. And I'd like to take a few minutes to tell you about a few of their products. One of their most popular products is Cortisol Manager, which is an excellent combination of several adaptogenic herbs and phosphatidylserine, which helps to modulate cortisol levels, which can sometimes be very helpful in modulating blood sugar levels, since cortisol surges due to stress can cause blood glucose levels to rise, which I'm sure Dr. Morstein will mention. Another excellent product in the integrative line is berberine, which has quite a bit of research to back up its benefits in helping to control blood sugar and to improve insulin sensitivity. In fact, some studies show that it is equally as effective as metformin and can also be used concurrently with metformin and has been shown to improve metformin's efficacy. This integrative berberine product is berberine HCl, which is not an extract of berberine from berberine-containing herbs, such as in their berberine complex, which is better for use as an antimicrobial for gut health. In other words, if you're using berberine for managing blood sugar or helping with lipids, then you want to use the berberine HCl. I personally use Integrative's berberine product for my patients because of its quality, both for blood sugar management, for control of lipids, and also as a longevity agent. So it's an activator of AMPK. One of the reasons why Integrative's berberine and their other products are such high quality is because the company uses a manufacturing facility that's a drug GMP facility rather than a dietary supplements GMP, which means that they test every lot. They do bioavailability testing, stability testing for up to 2 years past the manufacturing date, et cetera. So Dr. Mona Morstein is a naturopathic doctor in Tempe, Arizona, who's a practicing functional medicine doctor at Arizona Integrative Medical Solutions, which has a focus, and her practice has a focus on treating patients with autoimmune diseases, hormonal conditions, diabetes, thyroid, and gastrointestinal disorders like SIBO and IBS. She's the author of the best-selling book, Master Your Diabetes, a comprehensive integrative approach to both type 1 and type 2 diabetes. And I got to tell you, this is one of the most impressive, comprehensive, useful books that you would ever want to have. And everybody should have this on their shelf for help with managing patients with diabetes. Dr. Morstein, thank you so much for joining us. You have the floor.
Thanks very much, Ben. I really appreciate the intro. And I hope everybody can see the lecture, the slides okay. I wrote kind of as a joke an abbreviated diabetes lecture because it still is like 70 slides. But, I tried to extract, I've taught a lot of diabetes webinars to physicians. And, it's usually a kind of a weekend affair, all day Saturday and all day Sunday. So we'll try to touch upon a lot of things right now today. And I also know I'm speaking to physicians, so you're already coming with a fairly high level of comprehensive knowledge of this condition. So, okay. So he just mentioned me. This is me. I will say this. I don't think we talk about this enough in medicine, because it's embarrassing. But I got into diabetes because literally way back when, 30 years ago, I missed the diagnosis of a type 2 patient in kind of an acute crisis of diabetes. And so that really shook me to the core. I was a new doc just starting out in Montana. And it made me doubt if I was a safe, responsible physician. And so the end result was that I really just decided to never miss another diabetic patient. And I really immersed myself in this condition. So it was nice to take one of the most worst moments of my medical career and turn it into a real growth, trajectory that makes me feel very comfortable treating all types of diabetes in kids and adults and so forth to this day. So anyway, and then Ben already showed the book. You can get it on Amazon. It's a pretty good book. I'm proud of it. Thanks. Anyway, let's dive in. Kind of there are some statistics just to know about. We'll talk a little bit about type 1 and, of course, type 2. But most diabetes is type 2, 95% of diabetes is type 2, and it is related to many things, which we'll talk about, but obesity and being overweight and this, abdominal visceral fat is a big part of it. And as we can see, the US statistics on obesity are staggering, if we're going to choose any appropriate adjective. Even kids, 15%, that's so sad. And then in the world, right now, there's if we got 8 million people on planet Earth, about 2 billion are overweight. It's not a good thing. With, 650 million, about twice the population of the US are obese. So this is not a good thing worldwide. And it certainly is feeding into diabetes statistics. So in the US right now, when I did this lecture, say when I started 60 years ago, it was only 29 million. So it's now up to 37 and a little over million people actually have diabetes. 11% of the one out of, more, pretty much 1 out of every 10 people in the mall or you're going to see has diabetes. And pre-diabetes is almost another 100 million. So if we add that up, it is clearly 1 out of every 3 Americans have either pre-diabetes or diabetes at this point in time. With those senior populations, it's 50% of them have diabetes. You can't even really wrap your mind around it. So it's really not a good thing. It's a huge burden for these people, for the health, for our healthcare system, and for the economics of our country as well. In the world, we have right now over 500 million people in the world have diabetes. And it's, you can see the deaths and how many pre-diabetics there are. So if you add up pre and diabetes, really 1 billion out of 8 people have either pre-diabetes or diabetes. Now, the types of diabetes, again, I appreciate, there is type 1. This is our classic pediatric autoimmune disease. Doesn't really tend to start below 1.5 years. And then even though we call it kind of pediatric, it really, the bell curve is going to fade out around age 25. So older than our 18-year-old cutoff, but that we still consider that's all that initial pediatric type 1 type condition, right? So these it's an autoimmune disease. My next slide, we'll talk about that TEDdy trial. The other type of type 1 is called latent autoimmune diabetes of the adult, LADA. And generally, it's kind of kicks in from age 35 on, but the vast majority tend to be in their 40s. About 40 to 60 is where we're going to see that bell curve the most. Now, the big thing with this is that the vast majority of them are misdiagnosed as type 2. I've re-diagnosed literally dozens and dozens of patients who came to me lean, always been lean. They have type 2, and it's clearly type 1, right? So just be aware of that. There are still many physicians that are not knowledgeable about LADA and are not aware of type 1 happening in adults. And then this type 1 can be very slow onset, where they may not need insulin at first, or they may just need, I have one gal who's just needed 2 units of a basal insulin for a decade. She hasn't progressed. Or these people can come on just as rapidly as a pediatric type 1 and need full-blown, full insulin from the get-go. So you'll just have to be able to figure that out with your own patient. This is the TEDdy trial. Stands for the Environmental Determinants of Diabetes in the Young, so TEDdy. So this is a trial that's still ongoing, where they're following kids and the diets and their vaccines and et cetera. And they're looking at all of these factors as triggers for what seems to really be, an actual trigger that they can clock and start saying this is a determined trigger for type 1 diabetes. So they are looking at a very broad-based way of things, from nutrient deficiencies to vaccinations and getting sick and psychological stress, all of these things. So when they are able to quantify it and really put it together and put it out, they put out little bits here and there, but they haven't yet put the whole thing together. I think that'll be helpful to all of us to really be aware of what we need to watch in kids early on to help prevent them to not get type 1 diabetes. And then, of course, the last type, right? Well, not the last, third of 4, is type 2 diabetes, which is the number 1 diabetes. It's insulin resistance driven. Gestational diabetes is a type, is an insulin resistance type diabetes. And there are many, these are pretty well known etiological factors, and I'm going to talk about them more in the further slides to come, but all of these things can be, factors with, developing and also potentially having trouble controlling type 2 diabetes.
But by the way, Doc, if a type 2 diabetic ends up being insulin dependent, has that type 2 now become a type 1, or is it?
Yeah, that's a good question. And so, no, so type 1 is relegated to autoimmunity.
Okay.
And both you're going to be able to pick up for the vast majority. There are always a very, very small percent of antibody negative type 1 patients. And that just happens. But the vast majority will have a positive antibody or several positive antibodies. Type 2 diabetes, is generally poorly controlled, and these people will just become insulin dependent type 2 diabetes. And so they stay type 2. And there's a lot of patients who need insulin with type 2 diabetes. For me, unless the patient is literally completely in denial and refuses to change anything about their diet or their lifestyle, and there are some patients like that, but for a lot of them, they're just given misguided information from the physicians they go to, and easily the vast majority of type 2 diabetic patients never need to be insulin dependent. The last one is a relatively unknown one called MODY, mature onset diabetes of youth. And these are just genetic mutations. And these you tend to see, grandpa had diabetes and dad had diabetes and Timmy at 16 gets diabetes, but it's not that bad and they don't really need insulin. This is mild elevations, like their blood sugars are around 140 or so. And these are genetic defects. For example, they make insulin, but there's a genetic defect in their ability to secrete it. Or they can secrete it, but there's a genetic defect on the receptor that it doesn't acknowledge the insulin. So these are generally can be dealt, most of them have to do with secretion. So sulfonylureas, which are not good drugs that we don't really like, for this group of people is a good drug, right? And if they just take a sulfonylurea, they'll be fine for pretty much the rest of their life. So there's one lab, Athena Diagnostics, that does measure all of they measure 1, 2, 3, 4, 5, and 8 of the MODY genes, right? If you feel a child needs to be investigated that way. And just to put it together, a little chart of MODY type 1 and type 2, non-insulin dependent or parents effective and so forth. Acanthosis, nigricans, et cetera, and racial groups, right? Certainly we know with type 2, obviously many Caucasians get it, but Pacific Islanders are native people, right? We've been studying the Pima Indians with type 2 diabetes since the 50s. So, there are definitely our Hispanic populations, our African-American, very high risk for type 2. So diabetes, but controlled, nobody has any problems with diabetes when it's controlled. But when diabetes is not controlled, right? So, physiologically, the vast majority of our cells do have an insulin receptor. And when this pancreas secretes insulin, it lands on the receptor, sets up this phosphorylation chemical, and then that initiates the glucose transporters, particularly to reach out, grab glucose and pull it into the cell, turn it to fat and store it, or burn it as well. But we know insulin is called the fat-building hormone. Its idea is to store food for later. So the problem is there are 4 cells in the body that don't have insulin receptors, and the glucose is just going to osmolarity, walk into those cells. So those cells are your eye cells, kidney cells, nerve cells, and the endothelial lining of the blood vessels, which is why those are the ones that get damaged with uncontrolled diabetes. Because if your blood sugar is 300, your eyeballs are 300. Meanwhile, your fat cells and muscle cells and liver cells, they're like, forget it. I'm not taking you in. I'm going to be resistant. So they're not getting the glucose in, but it is getting in these other cells that by the nature of survival never want to be without glucose. So there's nothing blocking glucose from entering those cells. But this is why, the majority of people with diabetes have hypertension. When you have diabetes, considering if you're just getting regular treatment and you're not really well controlled, you have a 4 to 6 time increased risk of dying from cardiovascular disease, which is not a good thing because everybody dies of cardiovascular disease in America. So, you are really at risk. Chronic kidney disease, diabetes is the number one reason people wind up with end-stage renal disease. It's the number one reason adults go blind. It's the first reason people get amputations is trauma. The second reason is diabetes. So pregnancy and fatty liver, most fatty liver, which in America is still called non-alcoholic fatty liver disease. In Europe, and probably within a year or two in America, it is going to be called metabolic associated fatty liver disease, because that is the vast majority of fatty liver, right? So diabetes has outstandingly devastating complications. Now, and then this is like a daily diagnosis. We have 4,000 people a day diagnosed, 356 amputations a day due to diabetes. About 160 people wind up with end-stage renal disease, et cetera. And literally the amount of money we spend on diabetes in this country is very scary and could really become an economic burden for our country in the future. Now, labs. So this is like one page of labs to consider. Obviously, the basic CMP, CBC with diff and lipids, obviously. I always draw ferritin. I include ferritin on every lab, a yearly lab that I do. Ferritin 1, it's the first way to catch anemia. Before the CBC is affected, you're going to see low ferritin. So you can catch people before it gets very serious. But even more so, it's the number one lab that indicates a person has fatty liver. When ferritin is elevated, of course, you'll do an iron panel and look at trans saturation. And as long as it's not over 50 or so, they don't have hemochromatosis. And most people don't have hemochromatosis, about 2% of the population. But when that's negative, then you can do your ultrasound and see the echogenicity. So ferritin is the number one blood lab when it's high that indicates and that's as a liver acute phase inflammatory marker. The second one is elevated GGT.
By the way, Doc, on ferritin, are you using the lab range over 400? What are you using as high?
It depends on the lab. Some labs are over 250, some are over. Yes, I am using for high, I am using high. I am using high. If the lab range was 400 and they were at 380 and you wanted to, you wanted to test for fatty liver because they have a adiposity as a body type. I mean, there's nothing the matter with that, but I'm saying literally you're going to get a great deal of your overweight or obese pre-diabetic or diabetic patients will have elevated ferritin, and you'll do the ultrasound and they'll have they'll have fatty liver, right?
By the way, Doc, I don't know if you've noticed, but recently some of the lab ranges have gone up. I had a patient last week with ALT of 65. And I said, oh, your liver enzymes are up. And then it said normal. And there was an asterisk underneath. This was a UCLA lab. New reference range. It's now up to 70 is normal.
I don't think anybody who's a real, I just did a webinar series with hepatologists and things on liver conditions, and they're not going to agree with that.
Well, this is the normal range is the average American as a result of 2 years of pandemic drinking.
Oh, totally. Absolutely. I once called Sonora Quest because their postprandial insulin range was from 29 to 89. Now, when you look at studies where they are measuring postprandial insulin, pretty much the cutoff was around 30, where they said that, it should be not higher than 30. So I called Sonora Quest to research how did they get their range. Do you know, Sonora Quest said, oh, well, we just took 50 of our healthy employees, measured their postprandial insulin and got the range. And that's literally how they set up the lab value.
Wow.
So, and that's measuring millions of people, the lab ranges, we do have a right to be a little question them at times, right? So I agree with that. The other ones that you can see are fairly standard. Remember that as soon as someone injects insulin, you cannot measure insulin. You have to measure the C-peptide. Anyway, C-peptide is a better reader than insulin, I think anyway, but you can't measure insulin if they're a type 1 diabetes, because they're going to probably have insulin antibodies, or once you inject insulin, you'll make insulin antibodies. So we want to switch to C-peptide. The cardiac risk panels, because we know cholesterol is pretty bogus and to judge cardiovascular disease risk. So the other panels are better. Random microalbuminuria, you'll want to check at least once a year. If it is elevated, showing early kidney damage, you can repeat it every 3 months. Those are the diabetic antibodies. The classic one for LADA is GAD65, but I would just do the whole diabetic antibody panel because sometimes it's not GAD and it is a different antibody and you don't want to miss it. And then, of course, celiac and Hashimoto's, at least once a year with your type 1 diabetic patients, you'll want to check Hashimoto's. If they're literally gluten-free, you can't really measure for celiac, but if for some reason they're just going to eat gluten, then you'll want to check that every year as well.
What about the new kid on the block, uric acid?
Oh, yes. So uric acid, going back, uric acid, obviously elevated uric acid, not just gout, but it is an indicator of also, risk of kidney disease, even heart disease in patients with diabetes. I don't do uric acid that much because I think I already know their risk, a lot with some of the, what's their A1C, what's their, et cetera. So I don't do a lot of uric acid. I'll do the microalbuminuria. I'll do other things. But yes, it is an indicated lab. If you just want to throw that in, for sure. Thanks, Ben. Now, just to say, this is the conventional A1C lab reference ranges, right? Pre-diabetes, and then diabetes 6.5% and higher, right? The problem is with A1C, one, it always has a 0.5 variability. So if you get a 6, it could be from, 5.5 to 6.5. So there's always this little variability. Now, we do know the lower the A1s, these old studies are still referred to this day, right? The DCCT and the UKPDS done in the 90s, type 1 and type 2, showing that literally lowering A1Cs from 9 to 7 based on basic and then aggressive control made huge differences in the occurrence of complications. So, we still need A1Cs to be as low as we can. Unfortunately, even though they don't count person being pre-diabetic until it's at 5.7, their studies will show that an A1C over 5.5 is already beginning to cause damage in the body, such as to the eyes, or over 6, it's causing kidney damage. So in the pre-diabetic range, people are already having damage. So this is a problem because people, it's 5'7", whatever, that's not that bad. Well, okay, it's not that bad, but it is causing damage. So we do want to get people under control and get them protected.
I think there's a misunderstanding of what hemoglobin A1C is. I think a lot of people don't really think about it too much. And they just say, oh, this is 3 months of average blood sugar. And really, this means that proteins in your body are being damaged by sugar.
Well, yeah, I mean, the A1C is a protein on the red blood cell. And what we're measuring is what percentage is covered with glucose. So an A1C of 5 is 5% of those proteins are covered with sugar, and 6% is 6% of it. And it doesn't seem like much, but of course we can translate this to blood sugar numbers, and they go striking, each number decimal higher is about 26. So, 5 is 100, 6 is 126, 7 is 152 and up. There's a fairly exponential rise per percentage of this glucose bound to the A1C protein on the red blood cell. I do have this slide just showing there's different ways you can get an A1C of 6. You can have steady, good control, or you can be up and down all day with an average of 6. So, if you're at 50 half the day and at 150 half the day, you could get an A1C of 6. So we have to be aware that you always want to monitor blood sugar, not just take an A1C, because we don't know what the blood sugar is doing to get that A1C. And then here's a very, very busy slide, just saying when the A1C can be inaccurate. So there are, different races have different A1Cs, of course, the genetic hemoglobinopathies. If you do have a patient with a genetic hemoglobinopathy, like a sickle cell, you can't really use A1C. You'd have to use fructosamine instead. The only problem with fructosamine is that it doesn't translate to a glucose number. It's just normal, low, normal, or high, but we can't translate it into glucose like we can in A1C. And then different, depending on if they have serious liver, then, the A1C can lose efficacy as well. Liver, kidney, iron anemia, etc. And last, the problem with the A1C also was these studies. So these studies, particularly the Accord. So the Accord was a study where they had people eat whatever they want, because why would we ever deal with the diet in measuring medicines? So they had people eat whatever they wanted. Their goal was to get them less than 6.5% of an A1C. And as a result, they had to use a lot of strong medicines, which was sulfonylureas, which cause weight gain, and water retention, and TZDs, which cause weight gain and water retention, and insulin, which causes weight gain and water retention. And so they had a high amount of people dying. And so as a result of this study, I can't tell you the amount of patients who come to me and say, oh, my doc doesn't like that my A1C is at 5.8 and literally wants me to eat more carbs to get it higher so I don't have cardiovascular disease because of the Accord study. So just this is the Accord study. That's all and then the Advance, these studies use the worst drugs, that we have. This Accord study is what took the TZDs off the market. Now, they're back on, but very rarely used. So, but this is, probably all of you have also heard patients say, oh, my endo doesn't want me to get less than 6.5 because I'll get heart disease. This is ridiculous. It's solely based on the Accord. If I get a person on a diet and supplements and maybe metformin down to 5.4, trust me, they are not going to have a high risk of cardiovascular disease. So just to be aware. The ADA has these glucose goals. I think we all want it a lot more stringent, right? So And, because we can get it with the way we're doing it versus the way the ADA tends to do it. So, getting everything down back to as much normal as possible is the goal. These are the diabetic medications. There are insulins. They're basically split to basal, which is covering the fasting glucose, which is either long-acting or intermediate. MPH is the worst insulin we have. Certainly by far has the highest rate of hypoglycemia. Very hard to deal with. Some people need it twice a day. Some people need it 3 times a day. It can last for 8 hours. It can last for 15. It's a difficult insulin, but it is super cheap. And that's why we're seeing a little resurgence of it now in patients who can't afford insulin as it's priced now. And then, although I order a lot of insulin from Canada, right? It's much cheaper there. Or I have patients just drive down twice a year to Mexico and get, their pens for nothing, just walking into the pharmacy, right? Now, and then there's the bolus, which is meal or correction. We have short acting. Regular is by far the best for meals, but isn't used very much nowadays for, a couple of reasons. And the rapid acting, and then the very rapid acting, which acts within 5 minutes. So these are our insulins. We have the oral hypoglycemics. There's nothing the matter with metformin. You've got metformin, and then you've got the ER, because some people who can't handle metformin in the gut, the ER, they will be able to handle the extended relief. The sulfonylureas are problematic drugs, right? They do cause water retention and weight gain. They have the high risk of hypoglycemia. Glyburide is the worst one for low blood sugar. So we'd want to stick with like glimepiride. The metigloinides, nobody uses. Why would we use this? I could take a sulfonylurea maybe once a day for 24 hours. Why would I want to take a tiny sulfonylurea with every meal? Nobody uses them. The TZDs, I just saw a patient on one for the first time in nearly a decade, right? The sodium glucose transporter 2 inhibitors, not bad drugs, except they can cause, the sugar can cause bladder infections or jock itch or vaginal infections, but most people don't have this recurrently. You can get a euglycemic DKA in type 2s, which sucks. So you have to let people be aware of that. And then you have the DPP-4 inhibitors, which don't seem to be a problem very much. It's just that they're at the highest dose, they have a lowering of the A1C of like 0.4 or 0.5. And frankly, just taking out their grains will lower them 3.3%. So they're fairly useless drugs. They don't do very much, right? And then we have the glucagon-like peptide 1 agonist. These are good. These are great. Patients like them. Most of them can handle them, even with the nausea. Once a week shot, they can lose a little weight. Their appetite is better. Their blood sugar is better. These are good drugs. They're just spendy and not, so people have to hope their insurances will cover them. Otherwise, people are using for insulin, vials and syringes or pens or pumps, and then the CGMs, right? So Dexcom is pretty good. Freestyle Libre for the type 2s is pretty inaccurate. People get it, but it is not the best CGM.
So Dexcom is more accurate than...
Oh, yeah. Dexcom is 100% more accurate. Dexcom, I was trying to go backwards. There we go. Dexcom, is 100% more accurate than a Freestyle Libre. Absolutely.
I know Dexcom usually recommends wearing it on the abdomen. I've seen some people put it on the back of their arm. Is that acceptable? Do you know?
Yes, that is acceptable. Also back here in the back is, also acceptable. It's just sub-Q. So for example, this is probably the most common area people wear their Omnipod, pump. right? So, which is in the back here. So people love wearing their Omnipod here. And it's the exact same technology and depth. So with the Omnipod here, you can have your Dexcom here. So with diets, so the ADA in 2000 and really 13, 14, the ADA did acknowledge that low carb diets have value in working with diabetic patients. Now, if we go back so, what happened with the ADA is that, we had diabetic patients say that needed, type 1 diabetics 100 years ago, before, Banting and Best were inventing insulin in Toronto. We didn't have many type 2s, and the type 1s would die pretty awful deaths where they just, ate themselves. So then we invented insulin, and diabetic patients were able to live longer until they all died of cardiovascular disease. And then they're doing autopsies on all these patients with diabetes, and they had, cholesterol in their arteries. And if you go back to the 70s, that meant their fat was too high, right? So that was 1978 was when, the country said, wow, we should all eat low fat. Everybody started eating all these carbs, and things went downhill from there. But the ADA said, yeah, we're seeing all this fat in these autopsies, so we should have a huge amount of carbs in our patients with diabetes and not much fat. And so this has been going on for decades until recently, just in the last years, they're turning around, which is something for them to do. And they started acknowledging low carb diets is, a physician could do this in an acceptable way. For pre-diabetes, this Predimed diet is very well known, where they did, Mediterranean diet versus low fat and even metformin, and the Mediterranean diet, which is really just a super healthy, non-processed food, omnivore type diet, did, here's the study, and the Mediterranean diet with olive oil or nuts and no calorie restriction reduced diabetes incidence by 52%. So, which was higher than putting people on metformin. So, in other words, just eating a healthy, whole foods, omnivore diet with good oils can prevent diabetes. I mean, this is what pretty much everybody was eating until they invented fast foods. So, and candy bars. This has been a diet for humanity for centuries, and it works to not get diabetes. Now, this is, an outlier I think we need to discuss, which is the MAPI-2 diet. This is the high carb plant-based diet. Now, and there is a company, I wrote a book, Master Your Diabetes, but the mastering diabetes folks are doing this diet. This is what they're doing, this high carb plant-based diet. And there is actually good studies on this diet. They did 6-month study of this diet. Now, this was all men. This was all type 2 diabetic men who had pretty high A1Cs. And this was the typical diet that they ate. Now, the mastering diabetes people aren't doing macrobiotics, but this diet was what we classify as macrobiotic. And you can see just all kind of foods that we wouldn't think people with diabetes should eat. Now, and the results were outstanding in every area. And the A1C from 12 to 5.7, pretty amazing, right? Things like HDL went up, LDL went down. C-peptide actually raised a little bit. This is their lipids, the onset and after months, from acceptable, there was only 31%. After the 6 months, almost 94% of the patients had acceptable triglycerides, and pretty good stuff. They had weight loss, they lost hip circumference, their BMIs went down, their muscle mass gained. Like, this is everything we want to see eating this diet. Now, these guys were fed this diet. This is a hard diet for people to put together, but in the study, they were delivered their meals and, they just got everything fed to them. Now, this is kind of a bad, I copied and pasted. This is from the Mastering Diabetes group, and you can see what they want you to eat. A lot of, which is grains and legumes, veggies and fruits. And then what they want you to eat just a little bit of, which is, things like pastas, avocados, because, they're worried about too much fat, especially saturated fat, nuts, which isn't, too much fat. And then the other things that they don't want you to have at all, which is meat and poultry, and so part of this is the idea that animal protein, I think, interpreting this, I went to a lecture from Dr. Joe Pizzorno, who's a naturopathic physician, brilliant. He did one of the best lectures I've ever seen, which was on cellular acidity. Right now, in reality, our blood doesn't really change alkaline or acid because tiny changes are so devastatingly bad. But the cell, we're looking at intracellular, there can be acidic changes. And animal protein and salt are two of the main foods that cause the acidosis, and that is causing insulin resistance. So in this diet, removing all the animal products and, is really pulling out that whole thing. The problem is you can't eat half this diet and half this diet and, half of the other and have it all merge. This diet will work 100% its way, or low carb will work 100% its way, which is what we're going to talk about right now, right? So low carb, for diabetes, we're usually looking at 40 or less carbs a day, okay? And there are good, the studies on low carb, there are a lot of studies on low carb, but this one that I want to show you, if you look at the authors on this study, first of all, Richard Bernstein, Richard Feynman, huge low carbs. There are some really well-known low carb researchers. Eric Westman, big keto guy, and so they did this study showing being a dietary carbohydrate restriction, first approach in diabetic management. And this is what happens when you are doing a low carb diet, and pretty much everything we want to have happen for people with diabetes. So this was with type 2 diabetics. Then the pediatric managing type 1 diabetes with very low carb diet. This was published in Pediatrics. This wasn't a study so much as it was a survey. And they surveyed a group on Facebook called Type 1 Grit, which is a very, very passionately low carb group for type 1 diabetes. Notice Bernstein and Westman are in this. We have some, these same people. Dr. Richard Bernstein, by the way, was my mentor. He wrote the book, Dr. Bernstein's Diabetes Solution. He was the one who brought low carb diabetes low carb diet to diabetes. He also was the one who taught us how to use insulin better. Like, for example, using insulin to cover carbs, to cover protein, and to figure it out in a completely different way than conventional care. And that works a lot better. David Deichmann, he's a big low carb guy. So they did this, survey of parents of type 1 and here's the exceptional glycemic control of type 1 diabetes without adverse effects was reported by these people and their kids on a low carb diet with type 1, with the reported mean of A1C at 5.6, which is pretty outstanding. So, low carb diet is what most of us work with and what most of us want to do. But if one of my patients really wanted to do mastering diabetes 100%, I don't mind. The studies are good. They've been replicated. But you've got to choose one extreme or the other. So, it's total carbs minus fiber. It's not the amount of sugars on the label. It's total carbs minus fiber, right? That's what a label should be. And these are the low carb no's, pretty much, right? The big groupings of foods that we're taking out of the low carb diet, right? Which you probably know about. And then, Bernstein set up the idea of 6 grams of carbs at breakfast, 12 at lunch and supper because of the dawn phenomena at breakfast, raising our blood sugar innately. And so having less carbs at breakfast. And then as we're up and moving around lunch and supper, we can have a little more then. And fat is a free for all. And protein is also weighted a little bit as well. We don't want to overdo protein. We do need people getting in calories though, and having new energy and so forth. So we do a little, the protein is 1 gram per kilogram versus 0.8 for adults in general. And then we allow fat to make up many calories too. Now for these other, obviously you all know how beneficial exercise is to people with diabetes, with metabolic syndrome, prediabetes, people who are overweight, and et cetera. It does pretty much everything we need it to do to help reverse that in patients. And then, we can put it, obviously, aerobic. Resistance does burn like 19 times the glucose that aerobic does. Now, I'm not talking if you're going to decide to do a 10-mile hike with 3,000 foot elevation, then, the aerobic is kind of going to work pretty well. But if you're doing a half hour, on a treadmill versus a half hour of lifting weights, you're going to burn more glucose with the weights, right?
Doc, can I just ask you a question about the diet, just to go back for a second?
Oh, yeah, I'm sorry.
No,
I didn't mean to,
no, that's okay. Yeah. So the low carb program you're outlining, less than 40 grams, that's very, very low carbs.
Yeah.
Can you get a reasonable, benefits with, say, 50 to 100 grams? A lower carb program, reduces the high glycemic carbs, takes out the refined carbs. But say the person has maybe a slice of gluten-free toast in the morning with their eggs, and they have a yam with their dinner, and maybe they have some beans with their salad at lunch.
They're going to see elevations in their blood sugar. It just depends on how much, right? But generally, no, those are not on. If you're following low carb, those are not on the diet for low carb. Now, there are breads that you like. Why not have a piece of base culture bread? Or, if you go to dietdoctor.com, dietdoctor.com has amazing recipes. Like so many of they have these rolls, which are like 6 ingredients. You mix them together, you bake them, you get these super tasty rolls that are 2 grams of carbs per roll. So, the idea is there's low carb bread, there's low carb tortillas. You can make your own low carb, rolls. There's Birch Benders has low carb pancakes. You can get shirataki noodles. So the idea is when you're working with patients this way, here's the deal. For every 20 seconds you spend taking some food or food group out of a patient's diet, you want to spend about 5 minutes adding in the alternatives, because otherwise their psychology starts getting narrower and narrower and narrower. And it's not like they have to live. They could have base culture. A slice of base culture bread is 4 grams of carbs and 4 grams of fiber, which is going to even further reduce the carbs that they eat. So if they have a sandwich at lunch with base culture bread, that's 8 grams of carbs, 8 grams of fiber.
What kind of bread are you saying? It's not something I've heard of.
It's called base culture, BASE, culture bread.
Okay.
So, I'm saying that there are breads that people can eat that will work for them without it being Dave's killer bread, which you can't have, no, you can't have Dave's, you can't have Ezekiel bread, but try this bread or try this granola. There's I have a reference sheet that once I go through, I have a 8 or 10 page diabetes handout for the diet. So we go over everything. Then I have a reference sheet with recipe books, 315-minute low carb recipes. And, then, you want maple syrup? Well, guess what? Nature's Hollow has it. Birch Benders has it. Lakanto has no carb maple syrup made with monk fruit, right? So if you give people some of these alternatives so that the diet isn't this whole change, they can still have some things they really like, but it's low carb and it's going to do what we want to have done. That's how this is a successful protocol for them, right? That's how they buy in, and that's how they have success with it.
So in your opinion, you want to have success with the type 2 diabetic, it's got to be super low carb or you're not going to be successful.
That's how I work with patients. Yes.
Okay.
Now, otherwise, the rest of the exercise, I'm sure you had plenty, the only thing with exercise is that if they're insulin dependent, I have a whole lecture on doing exercise with insulin dependent diabetics, because depending on the intensity, the length, so forth, you're going to have to figure out how to deal with their insulin before, during, and after. So you can get pretty good at it. You just need a little data to make these decisions. But that's the most difficult patient to work with initially, are the insulin dependent who are starting to really dive into exercise.
So Dr. Wasserman asked, you showed some slides about the Mediterranean diet as being helpful in preventing diabetes, but now you're saying no way.
No. That's if you don't have diabetes.
Oh, okay. That's preventing it from happening.
That is preventing it. Now, if you have it, that you've stepped over that line, and now we got to yank you back a little more tighter. So, yeah. Now, I just have some things with blood sugar and exercise. It does matter where the blood sugar is when they start in terms of how well they'll be able to exercise. The golden is, I don't agree with this 65 to 180. I tell patients to mostly be around, maybe 80 to 170 is, if they start exercising around there, they're going to have better effect. And the same with where their insulin levels are, if they're on insulin, and how it'll affect their performance. So I'm working right now with a 16-year-old teen who's a cross-country skier and has desires to get into the Olympics and so forth. So, we've been getting really good at figuring out his food and his insulin, before and after his races. So it's, you just need a little data a couple times and you can figure this out if you have some aptitude with insulin and work with patients who are also athletes.
Do you work with do you recommend a insulin pump?
So I'll let patients decide what they want to do. Some patients for sure do not want something embedded in them 24/7. They just don't. Other patients love it because they don't have to inject themselves 5 times a day. So you can have good control or bad control with any system, right? So, and you can also have success, with any system. Now, pumps do give us a better control of basal insulin because we can direct the basal, all throughout the day, exactly how that patient needs it. Versus I just inject in the morning and I just inject in the evening and there you go, it's set. So pumps are the best for basal. They're not good for meals. You can't use the pump to decide what meal your insulin you're going to do because they're just doing the typical conventional figuring out of glucose, which is not a good way to do it. So you're going to have to still figure out your insulin for the meal and then tell the pump what to inject. But it is good for basals. It's just that you can't demand a patient get a pump and not every patient wants them. So you're going to have to work with, the basals elsewise, right? In terms of stress, so this was an interesting study. It was stress management. Everybody was a type 2. They had treated, which was 1.5 hour groups for 8 weeks. And in the people that got stress training management, look at their drop in their A1C. I mean, that's ridiculous. That's better than any medicine, any oral hypoglycemic, or even better than a GLP-1. The stress management is dropping better than any of those medications versus the control, which had really no statistically significant drop. So, and the thing with stress is that stress can worsen diabetes, but diabetes can worsen stress. So we have to be aware of the psychology of having diabetes. What am I going to eat? I have to check my blood sugars. I thought I ate right, and yet now I'm at 170. This sucks, blah, blah, blah. I've been exercising more. My A1C is still 6.6. It's an intense condition, and it's 24/7. So we want to be there always for patients. We always want to be finding everything positive that we can, giving them support, acknowledging when they get burnt out, and, helping them work through it, right? But the stress is, the arrow is, both ways. With the microbiome, again, its own lecture, but we have seen that with type 1 diabetes, they have found elevated zonulin and occludin in type 1 in patients who have positive type 1 antibodies, but have not yet had the clinical disease show up, right? So that's interesting. We also know that short-chain fatty acids, right? So fiber fermented by the Firmicutes bacteria family turns to short-chain fatty acids, which is really it's the food of the colon cells, but it does a lot of things systemically. One is help produce GLP-1 from the intestines, which will help us monitor our blood sugars better. So are people eating enough fiber? In fact, even with a low carb diet, we do need to make sure they're getting enough fiber in. They may need a fiber supplement because low carb diets have been shown to decrease the amount of the Firmicutes family, which are the fiber eaters and short chain fatty acid producers. So we do need to make sure that they're getting good fiber in on the low carb diets.
Yeah, there's a company that's now producing Akkermansia muciniphila, and they have it in a product that's been shown in a study to help manage glucose.
Yeah, all right, that's good. That's
That's one of the butyrate producers.
I will admit I'm very wary of any one probiotic really working systemically if everything else isn't coming together. You know what I'm saying?
Sure.
So now the lipopolysaccharides, so these are associated with type 2 diabetes, insulin resistance, and fatty liver. So, this is having a healthy gut on many levels, fiber that makes short chain fatty acids. It's not leaky. It isn't overproducing the lipopolysaccharides. These are all gut-oriented ways. We know that gut tumor necrosis factor alpha can get into the systemic system and go to our muscle cells and produce insulin resistance. So the gut is really important. Having a very healthy gut is here's another study with endotoxins and diabetes. So type 1s who had the macroalbuminuria had higher LPS. They had higher LPS in patients with diabetes and hypertension. So it's amazing how these gut problems can cause havoc so systemically. And then with environmental detoxification, there are, even the World Health Organization wrote that lead and arsenic causes insulin resistance and an increased risk of diabetes. Mercury as well. Now the PCBs are very well studied for gaining weight and becoming diabetic. The phthalates, which I may have spelled wrong, I don't know. It's hard to spell the word phthalates. And then they studied the Canadian Aboriginals with their high risk of diabetes, a much higher body mass of environmental chemicals. There is this organization, diabetes and environment.org. This is it's a nonprofit created by a researcher woman whose son developed type 1 diabetes, and she collects all the research on environmental impacts on type 1 and type 2 diabetes. And she has a free newsletter that you can get, I think it's every week or at least every month. Sarah somebody, I forget her last name. But here, I think one of the most important studies was this bottom one that I made red. So they had two groups of obese patients that were equaled out in age and smoking and drinking. All of that was the same. And then they had one group had diabetes and one group didn't, though they had the same obesity. And what they found that was different in this group with diabetes was the significantly higher levels of persistent organic pollutants in their fat through fat biopsies. So you've got overweight people. Who's going to turn into a diabetic? Likely the one that has more environmental chemicals in them, such as POPs, PCBs, etc. So this is, it's pretty frightening given how much people use these at home, and it's on our food. And, these are, if you walk into a store, they've been spraying toxins for bugs and stuff. We can't get around it. You see this fantastically horrific statistic that newborns have almost 300 chemicals now in their cord blood. It's crazy. So we do want to detox patients, getting their house cleaned, no fragrances at all, have all their supplies and body stuff being clean, using natural weed killers or pulling them. Here in Arizona, there's an exterminating company that's all organic. And I used to use them now, thank God. But I had a big ant problem. The ants here suck in Phoenix. So they would come and they'd spray peppermint oil. Literally, when they left, not in the house, they never sprayed in the house, but outside, they would go and they would peppermint oil. But honestly, now diatomaceous earth works fantastically. So, we got to retrain people to not, have all these chemicals around in their own homes. And then to detox now sweating. So there's loads of studies with sweating. I have them. I didn't put them on the slide, but sweating releases chemicals, heavy metals, even mycotoxins like ochratoxin has been found in sweat. When I went to medical school, when we did dead lab, dead lab, just working on cadavers. It was in a place, it was in a really an old RV that didn't have any ventilation. It was disgusting. And so, of course, all the formaldehyde. And so what we would do is, of course, we wore, onesies of plastic and whatever. But nonetheless, as soon as dead lab was over, we'd run to our gym, which had a sauna. So I'm in the sauna maybe 20, 25 minutes after class, and I could taste the formaldehyde coming out of my skin. I could literally taste it in the sweat. It's crazy. So people don't sweat in America because it looks, oh my God, I have an arm thing. So we want to teach patients always sweat. Wear enough clothing so that when you exercise, you sweat. Get a sauna, sweat in it. Go out, sweat, just sweat. It's so detoxifying. And then there's many other things with detoxification that, like, I'm already probably boring you in overtime, but I don't have time to do it. But you guys already probably know how to detox mold or chemicals, heavy metals, but for the diabetes, all of these can be a problem for diabetes. But number one, if someone's finances are limited, you definitely want to do chemical testing. That's number one for sure. This is my last section, is supplementation. Supplements do everything from better mood to antioxidants. Now, diabetes causes damage through oxidative pathways. That's what it's doing. There's the hexosamine pathway. There's the browning pathway. There's many pathways of pro-oxidative damage, going on in the body that's causing diabetic damage. So you always have to put people with diabetes on antioxidants. Aside from other ones, like I will always put people on a multivitamin. I always put people on a fish oil. But the next thing is antioxidant protection. So their blood sugars will not cause damage in that regard. And not only that, but you can reverse neuropathy. You can reverse kidney damage. And not that this is like, I have an obese guy who went off the wagon over the last couple of months on his diet. And he had positive random microalbuminuria. And so I have him on some antioxidants, and I have him on this great tincture. It's from Heron Herbs. It's called Two Treasures. It's such a great kidney protection formula. And so he's on it. And so even though his A1C went up, his kidneys remarkably got better because of the antioxidants and the herbs, which was amazing and surprising, but beautiful to see. His kidneys really got a lot better. So our antioxidants and our supportive products really can make a difference in these patients.
What would be your full program for a patient with kidney disease as far as supplements?
Well, let's go through some of them, and I'll give you, I'll give you, I have a supplement summary.
Okay, good.
Yeah, fine. Now for type 1, prevention, fish oils reduce risk, and so does vitamin D3. So, there's no reason an infant can't be on, can't be on 1,000 IUs, a day. And if he's breastfeeding, mom can take fish oil, which mom should, because fish oils are really good at preventing postpartum depression for her to take it during pregnancy and afterwards. But, or you could even, I would just do that through the breast milk for a breastfeeding newborn. But, as they get older, putting them on fish oils and vitamin D, this is just a good thing. Especially if there's, God forbid, any autoimmunity in their family. Now, if they develop a honeymoon, there are studies that showed these, niacinamide alone or with vitamin E actually can help prolong the honeymoon. Now, you might also want to throw in a pancreatic glandular. You might also want to throw in Gymnema sylvester, an herb that's been shown to help revive the pancreas and even increase the C-peptide. So now, and it's not niacin, it's niacinamide. But you can see it doesn't prevent people from getting diabetes, but if the kids enter a honeymoon period, this can help extend it. And honeymoon periods, they can go for years. I have worked with kids who had 7-year honeymoon periods. I mean, it can also just last for weeks, so we don't ever really know. But you can, we want to try to extend that as long as we can if the child initiates it to begin with. We never really see it in our type 1 adults. Now, supplements. So if you're adding supplements, you're not going to have to adjust the insulin. It's not that extreme, so don't worry about that, okay? Benfotiamine, if that's how you pronounce it, is a fat-soluble thiamine. Now, this kind of twists us because we usually think fat-soluble is a little harder to absorb than water-soluble, but not benfotiamine. It's much more absorbable, and you can see the biochemistry where becoming the thiamine pyrophosphate increases transketolase activity, and that blocks glucose damage. It prevents that browning glucosylation of sugar landing on protein, right? And so that's what it's blocking. And this is amazing, and it's very good. The therapeutic dose is around 450 milligrams. And there's studies in protecting neuropathy, retinopathy, nephropathy. Well, that's what we're looking for, right? So it's totally safe. I have a product. This is totally proprietary formula, all me, but I made a product called Diamend, and, it has benfotiamine in it at therapeutic dose. But even if you're just doing it by itself, it's a really good product. Mixing it with alpha lipoic acid or just giving alpha lipoic acid, and particularly R alpha lipoic acid, because the S alpha lipoic acid is not active in the body, but the R is. So this is also shown to normalize ag formation, the advanced glycosylated end products. Hexosamine is an oxidative pathway. So it's really helping people.
What dosage of lipoic acid or R lipoic acid?
With alpha lipoic acid, you'd want to do at least 300 to 600 milligrams a day of R. Now, if you're doing just alpha lipoic acid, which is half R and half S, then you'd want to be around 1,200. So you get that 600 of the R, and you could throw out, in your body, the 600 of the S. Other supplements, vitamin C, preventing the aldose reductase pathways in your eyes. So when you have a blood sugar of 200 and your eyeballs get 200, that's too much stuff in your eyeballs. So it starts offshooting a lot of antioxidants to keep the osmolarity from, your eyes from blowing up. So meanwhile, then that's turning to sorbitol, and it's using up the antioxidants are thrown out, and we get fructose, and then we get cataracts, we get retinopathy, and so forth. Now, vitamin C and bioflavonoids inhibit that initial pathway. The problem is we have to watch vitamin C with people with diabetes, no more than 1,500 a day, because it looks like glucose, and it can raise glucose levels on some glucose meters. We know that when we give IV glucose, usually people need to have a snack, because that can kick out their insulin and lower it, right? So when we're giving vitamin C, right? So a little C and bioflavonoids are fine. the alpha lipoic acid, NAC, N-acetylcysteine does a lot of stuff for people with diabetes. Of course, we always think of it with producing glutathione and liver and lung protection, but it does decrease insulin resistance. And of course, a very good antioxidant in general. So nice taurine, good for the eyes, especially with retinopathy. It's the number one amino acid in the heart. Of course, it does help make a bile salt in the gallbladder, but that doesn't tend to be necessarily a big thing with diabetics. The fatty liver could make a gallstone, however. The acetyl L-carnitine at 1,500 to 3,000 milligrams. Even Diabetes Care Journal, which is from the ADA journal, has good studies showing how it reduces peripheral neuropathy. Very good, safe one. Magnesium tends to be the number one nutrient deficiency in patients with diabetes. So maybe checking the red blood cell magnesium as well. The Gymnema sylvester, which is called Germer in India, sugar destroyer, decreases cravings, helps increase pancreatic functioning. Here's a really great thing for your patients who have very little willpower, particularly around the holidays, is that if you have Gymnema sylvester in a tincture, and I used to do this when I was at the medical school and saw students, we would eat a little organic raisins, so sweet. Then put a couple dropperfuls of Gymnema tincture in your mouth for about a minute and then swallow. And you can't taste anything sweet for up to 1.5 hours. So you put raisins in and they're the disgusting things you can't taste. You have to spit them out. So for patients who cannot control their cookies at the holiday parties, put some Gymnema in their mouth and swallow it, and they can't taste it. They'll have to spit it out. You can't eat it. It's really intense. Very helpful. And then, of course, curcumin, just awesome. Tumor necrosis factor alpha, as I said, is an insulin-resistant factor. It's an antioxidant. It's an anti-inflammatory. We know it reduces Alzheimer's in diabetic patients. Ben already did all the talk about berberine. I do have the method of action.
By the way, do you have a favorite form of curcumin?
Curcumin for sure. I think the best is Designs for Health Curcueval. That stuff kicks butt, I think. So that's the one I use, is Curcueval by Designs for Health. And then here's the berberine method of action. It's just like he said, the AMPK, everything it does. Green tea, blueberry. I think if I had to choose between Gymnema and bitter melon, I will always choose Gymnema myself. Of course, we have the old cinnamon studies, at the 1, the 2, and the 6 grams a day, how it helps. It doesn't hurt anybody to do cinnamon. They have done a lot of studies on it.
Doc, what dose of Gymnema sylvester?
The Gymnema, so, anywhere from 3, and my product, there's 1,000, but anywhere from 400 to 2,000 is a good, safe dose. And, and you should see some effect. Now, if you have patients who have proliferative diabetic retinopathy, and you're going to lower their blood sugar, you could cause them to have a bleed. And you cause them to have a bleed because when the blood sugar goes down, the insulin goes down, but then insulin-like growth factor comes out, and that causes angiogenesis, and that causes a bleed. So I did cause a bleed in a patient with PDR early on, and that was horrifying because they needed laser. It was a fiasco. You feel terrible. But then I decided to not have that happen anymore with patients who had PDR. So I know it looks like a lot. They only need to be on this for a month or two with the initial lowering of the blood sugar. But in 2 other patients with PDR, they never had any problems with their eyes. It was very stable. Now, I put everybody on a multiple vitamin and fish oil I will use my diabetic product, which means it contains alpha lipoic acid, it contains bilberry and NAC and benfotiamine. So that product contains that stuff. So I would add in taurine and a little selenium, and you're going to protect these eyes so they don't bleed with the sudden drop of the blood sugar in their eyes. But before you do a low carb diet, you got to, if patients are like, I haven't been to the eye doctor for a couple of years. You're like, okay, you go. And when you're done, come back, because I'm not going to put you on a protocol until I know what's going on with your eyes. And then, so this is the supplement, basically a multiple vitamin mineral, fish oils, comprehensive diabetic product, or, breaking it down individually. Probably some vitamin D3. I use vitamin D3 Complete from Allergy Research that comes with vitamin A, because you need vitamin A because the vitamin D receptor is bound to an RXR receptor, a retinoid X receptor. So if they don't have enough vitamin A, their vitamin D receptor won't work and the whole process doesn't work. So you have to throw in a little vitamin A, K, and so forth, right? So that's my lecture. I'm sorry if it went too long.
No, it was awesome. Can you mention that herb that helps with kidneys?
Yeah. Let me, I can write it. Should I write it in the chat?
That'd be great.
So it's from Heron. So it's Heron Herbs, which is owned by Eric Yarnell, who's a master herbalist. And his specialty is men's health and kidney health. And so he made this product called Two Treasures. And that's it's a tincture. And so that's what I use. I use that with patients who are on lithium, people who have kidney damage for whatever reason. It's a really great.
If you have a patient with chronic kidney disease, what would be your full program? What else would you put them on?
It depends. If it's a IgA nephropathy, I'll do food sensitivity testing of IgA, right? Not IgG, but IgA. Huh. I use Allotest, and they have an IgA option. They have IgG. So I would do that, tidy up the diet. There's, fish oils are great for the kidneys. Ginkgo and salvia, salvia miltariza is great. This Two Treasures is great because it has a lot of the other herbs, the parateria, the rhubarb, all of the other herbs that we have science. Like I have a whole lecture. I think I might talk about it in my book, but I have a lecture on treating more specifically complications in patients with diabetes. And I go over the science and the herbs and so forth with them. But you'd want to do a cordyceps. So there's a naturopathic physician, Jenna Peterson, who had kidney disease, and that's her whole practice, is treating kidney disease. She wrote a Townsend article and said for sure cordyceps is with kidneys as well. So
data on astragalus.
Well, she specifically said some, cordyceps.
Okay.
But, when is astragalus going to, hurt anything?
And of course, we have modified citrus pectin.
Yeah, I guess I don't use that for the kidney very much. That's mostly I use to prevent cancer metastases, but I haven't used it. Thanks. Thank you. I actually hadn't known to use that for the kidneys.
Yeah, apparently it prevents fibrosis of chronic kidney disease. There's some data on it.
Certainly, so does the alpha lipoic acid and the benfotiamine.
Okay.
So good. For sure.
Excellent. Okay. Well, that was awesome, Doc.
Thank you. Thank you, everyone. I appreciate that. Thank you.
Absolutely. And thank you, everybody. See you next month. Thank you, Mona.
Okay. Take care, Ben.
Okay. Bye. Thank you for making it all the way through this episode of the Rational Wellness Podcast. And if you enjoyed this podcast, please go to Apple Podcasts and give us a 5-star ratings and review. That way, more people will be able to find this Rational Wellness Podcast when they're searching for health podcasts. And I wanted to let everybody know that I do now have a few openings for new nutritional consultations for patients at my Santa Monica Weitz Sports Chiropractic and Nutrition Clinic. So if you're interested, please call my office, 310-395-3111, and sign up for one of the few remaining slots for a comprehensive nutritional consultation with Dr. Ben Weitz. Thank you, and see you next week.